Hi, everyone. I'm Dr. Lisa Konick, and I welcome to our talk today. This is an Ask an Expert panel on destigmatizing mental health treatment among first responders, trauma-informed care. And as we let attendees start filtering into the group, I'm going to start our introductions. This topic today is brought to you through the collaborative effort of Konick and Associates and Rosecrance. Rosecrance is a leading provider of behavioral health services with nationally recognized addiction treatment programs, serving clientele in locations across Illinois, Wisconsin, and Iowa. And Konick and Associates is a family behavioral health practice that specializes in the treatment of individuals and families across the lifespan. Our clinical team has expertise in treating a diverse range of clients and their families, including stress, anxiety, depression, high-risk behaviors, substance abuse, and trauma. And today I have with me Dr. Terry McCormick, who is our clinical resident at Konick and Associates and the trainer in trauma-informed care. Welcome, Terry, as one of our experts today. And I also have Dan DeGryse, who is the director of the Florian Program at Rosecrance, speaking today. Welcome, Dan.
Thanks, Lisa.
Both of you are former first responders who have transitioned into the mental health field. And we are really excited to hear from both of you about trauma-informed care and treatment for the first responder community. I'm going to let both of you talk a little bit about your background. Terry, tell us about your background and how you came to be in this spot.
Sure. So I have 15 years as a sworn police officer and 30 years involvement in the criminal justice system. I then transitioned into the field of clinical psychology approximately 10 years ago. And my main focus now is working with first responders, having awareness of some of the struggles that first responders deal with on a day-to-day basis and some of their concerns entering into treatment. Which then led me into focusing with trauma-informed care, and here I am.
Thank you, Terry. And Dan, tell us about your background as well.
Well, I grew up in the first responder world. My dad was a Chicago police officer and a former Marine. I became a firefighter, but I first got into the field of behavioral health before I got in the fire service. I started in '86 after I graduated with a bachelor's in psychology. And then after working in the field of behavioral health with adolescents with severe behavioral disorders and substance use issues and getting into fire service, I started working with our own members as the EAP coordinator for the Chicago Firefighters Union for our 8,000 active and retired members, which led me to working for many different organizations, the IFF, the National Council for Behavioral Health, Illinois Fire Service Institute, and then Rosecrance in 2014 when we started the Florian Program.
And tell us, I think when we're speaking about first responder community, and I want to say for our presenters, we have potentially members here of the first responder community, their family members, and also clinicians who are tuning into this talk today. So please feel free to put any questions in the Q&A in the chat, and we will hopefully be able to address those during this talk today. I'm going to be moderating the talk, and we're going to be asking both experts some information, giving them a chance to talk about trauma-informed care. Dan and Terry, tell us, when we think about the first responder community as a whole, who are these individuals in the community?
Well, I can offer from myself, it's grown over time. When we started the program, Florian, it was specific to fire and EMS because that's who I am. And that was in 2014. In 2017, we expanded it to uniformed service personnel. And it's really, you got to ask yourself, who are those people that are in uniform that manage crisis? And I would offer to people, well, what about flight attendants? What about teachers? What about jail guards? What about pastors and chaplains and clergy? Everybody, and then going even as far as parents. We are as fire and police identified as the first responders, but for the greater majority, we're second or third on the scene. The people that are involved in the incident are there. The people closest to them, if it's a family member, are there first, or a bystander is really the first responder. So it depends on what your definition of first responder is.
That's a great kind of summary. I think when we think of first responders, we may have a very specific spot, but it is a broader scope. And I know, Terry, even during COVID, during the pandemic, we're looking at behavioral health clinicians, social workers, medical personnel, nurses, also being represented among the first responder community and having those stressors and experiences of vicarious trauma. And when we're talking about that, Terry, can you kind of give us a definition of what that means?
Sure. So vicarious trauma, it's a secondary trauma. So it's somebody who is involved with seeing day-to-day tragedies of sorts. So maybe they're not directly the ones that are fearful for their lives, but they are the ones that are assisting others who have been involved in, possibly some horrific events. So it could be medical personnel, from ER nurses and doctors to firefighters, EMS, police officers. And like Dan had pointed out, family members who are there witnessing. Sometimes they could have the primary trauma, but the vicarious trauma is that secondary, where you're seeing it day in and day out, people at their worst.
If I could just offer a great description, is a clinician was the one that actually came up with it, Dr. Perlman, back in 1995. This has been going around for decades, and clinicians were experiencing symptoms as though they experienced the trauma themselves. And so it wasn't primary trauma, it was secondary trauma. So Dr. Perlman identified it as vicarious trauma.
That's a great description. We have a question here. Based on what I know, trauma informed is different from, let me get this over here, full trauma therapy. When do we know it is time to transition from trauma informed to a trauma expert for therapy? And I think we'll be getting to this question on a little bit in our talk. I want to, and if not, Robert, we'll get back to that. What I'd like to kind of add in here is when we think about the stigma of seeking mental health among the first responder community, speaking as members of the first responder community, where does that fear or aversion to mental health treatment come from? Terry, can you take a shot at that first?
Sure. So I can speak to within the law enforcement community and my own personal experience. A lot of times we get those calls to the same households, those individuals who have the mental health diagnosis and perhaps have been off their medications. So having that preconceived notion of what mental health treatment is oftentimes is seen, the individual in crisis. So having a fear of being similar to perhaps what we would refer to as that psychiatric call or that psychiatric patient, when it's on a continuum of mental health treatment, not necessarily at the chronic level when you come into treatment. And there's also that fear of entering into treatment amongst the first responder community that administration will find out, that police and fire boards will find out, that it's going to impact their duties, or they'll be sent for a fitness for duty evaluation, and perhaps then this is their livelihood, and what impact is that going to have? There's also a fear that others, their peers, are going to know that they're in treatment. Some of the dark humor that is used amongst the first responder community, it's used in a way to kind of make light at times. It's a survival tactic, it's a coping skill. And oftentimes when a diagnosis is given to a first responder, some of the jokes then, they may not respond in that same manner, and kind of may take it more personal to heart. And that too, having that fear of that diagnosis may keep them away. I don't know, Dan, if you have anything maybe to add?
Yeah, I would just want to echo. Oh, I don't know if that was
We got an echo.
So I will echo what you said in the sense of the loss of the job. That's number one. It's the fire, police, military, dispatchers, as it was brought up, nursing, doctors. It's not a job, it's a career. It's a lifeline. And the fear, the thought of losing that, no way. So we will do or not do things so that we don't lose that career. The other piece is being less than or identified as a weakness, is that many of the people that I know that get into the fire service, athletic, A-type of personality, military personnel, always striving to get to the next level. One of the things that we say in the fire service is you don't give up the pipe, you don't give up your ass. Even if you're on your last breath, you don't do that. Well, that could be your last breath, but we don't want to be less than. And we don't know what our breaking point is. And military people understand this, is that we don't know what our breaking point is until we reach that. We don't know what burnout is until we reach that unless we get educated. So there's a thing called self-efficacy. We know we can get through a lot of stuff until we can't. And then the question is, what have we been taught and how to address that? So that piece comes from an educational standpoint. And really, in my career, and I think in yours, Terry, and many, we haven't had the 101 class on when is enough and what can we do.
Thank you for that. I think there is across a lot of clinical spaces that perspective of, mental health there's a vulnerability that caregivers, we talk about first responders are the caregivers. They're the protectors, and that vulnerability is certainly something that is hard to acknowledge and be in touch with. And I think that goes to the next question is, how are members of the first responder community likely to cope with the stress of the job without mental health supports in place? Dan, can you speak to that initially?
Well, you mentioned the word vulnerability. Is that from the community that I've been in, and I look at the police, my dad was a Chicago police, I grew up around that world. Is vulnerability is a bad word. It's a 4-letter word, and you don't put yourself you put yourself in crisis and manage that, but you don't become vulnerable. So for us to ask people to be vulnerable is like an oxymoron. It's the opposite side of that. In our head, it's like, I can't be vulnerable. I can't be vulnerable. So I cannot talk about the things that I have conflicting thoughts on, cognitive dissonance. So if I have conflicting thoughts, I got to march through that and I got to get it done. As military personnel or Navy SEALs who I've spoken to, they say, I got to crush it. Well, unfortunately, then over time, as we've learned from the pandemic, if we don't have a conversation about that and the fact that we can only eat so much or we only can work out so much and we only can take in so much trauma, both primary and secondary, it might crush us. So how do we learn that? And a lot of times these days from our mentorship and our modeling from the people above, they don't show that they do have to take care of themselves. So we have to do it better. We shouldn't be starting in 2022. We should have started in 1982 on modeling vulnerability, not from a weakness standpoint, but just like, hey, what do I need to do when I'm tired or having these thoughts or struggling with cognitive dissonance, which we all do.
Terry, what are you seeing when it comes to coping without the mental health supports in place?
Sure. So what I see oftentimes without the supports is, especially within the law enforcement culture, is oftentimes we're going to have, debriefings at the bar, right? So we're going to drink, we're going to numb it, we're going to pretend it's not there. And then also what we see is a lot of anger, A lot of the anger after everything is suppressed, it's got to come out somehow, some way. So it comes out oftentimes in anger, especially because anger is more acceptable, I think, than vulnerability. And then that then leads oftentimes to domestic violence. Unfortunately, there is a high level of domestic violence amongst our first responder community when mental health treatment is not provided. It's unfortunate, but it is there.
I think also when we think about how do people cope with stressors, substance use is another major factor that can come into play. Isolation and withdrawal. Any thoughts further about that, Terry and Dan?
Yeah, I was going to say substance use is not a problem until it's a problem. I mean, alcohol provides a desired effect. It's calming. It's like smoking. I'm not a smoker, but I know when I chat with people in regards to when they inhale, that's a breathing technique. They're just inhaling something that's probably not good for them too. So from drinking, that's socialization, as Terry said. There are identified establishments that we frequent, sometimes too often, but it builds that camaraderie. It's usually around a substance of some sort, but it gives the desired effect to our system, which is usually charged on high alert. And how do we decompress? How do we bring that down? I could tell you for myself, driving home is not decompressing. Driving in the streets is not decompressing. So when we come home, most of us first responders, if we didn't go to a bar or a restaurant or something, we came home with all those thoughts and energies. And unfortunately, when we tried to engage our family, they were in one state of mind and we were in a different, and it didn't mesh.
Yeah. Now, as first responders, and as a clinician and a first responder, how should a therapist approach some of these concerns when a first responder enters into treatment? We have some clinicians tuning in here, and I also think we want the first responders who are tuning in to hear about this too. What are some of the do's and don'ts that a clinician can think about when working with members of the first responder community, and what might that be like for them entering into treatment for the first time?
Well, from what I've seen is it's very difficult for the first responder to make that first call, to even maybe make that first search for help. It might even take months or weeks of internal dialogue before making that outreach. So that first step is very difficult. So it's recognizing that. And it's recognizing when that phone call does come in, how to handle that phone call, and if possible, to get that first responder in as soon as possible, because the appointment could be made, but if there is a wait for that person to get into treatment, we might end up losing them in the sense of they may have a change of heart and not follow through. But from the time the call comes in, if we can get them in right away, we have a better opportunity to provide that treatment. Also being aware, and this is where the trauma-informed care comes in, also being aware that from the moment they take that step to enter into treatment, being aware not to re-traumatize them. It could be something as simple as, the decor in the office. It could be something as simple as the interaction on the phone. Our first responders, for what they've experienced, might be very hypervigilant, have avoidance tendencies. It could even be when they do come in for that first session, the amount of anxiety that they're experiencing, not knowing what to expect. So kind of normalizing the process, letting them know that they do have a voice, that they are going to be part of their treatment. It's not going to be that we're going to tell them this is what you're going to do, that they do have a voice, help them feel empowered and resilient, and have transparency. If we're going to do a mindfulness or a hypnosis technique, letting them know about, okay, you're going to be closing your eyes. Are you comfortable with that? And if not, let's change the protocol to something you are comfortable with, recognizing that in certain situations, they're not going to be comfortable with maybe some of the techniques that we do use.
I can imagine. Oh, sorry.
Go, Dan.
I was just thinking when Terry, because she said she deals with a lot of law enforcement, I could imagine when you tell a law enforcement officer to close their eyes, you're like, are you nuts?
Right. So then I'll have them, okay, pick a crack in the wall or stare at the corner. You can keep your eyes open, and then if you do eventually feel comfortable after we build up some trust, oftentimes then they might feel more comfortable closing. But at the onset, it's a definite no.
Yeah, Terry hit some perfect things. What I would say is that we have a certain metrics that we're measured on, and that's response time, both police and fire, nursing, dispatchers, everybody, right? And so when we don't get the same response, we're not very happy. A lot of times that phone, whether it be a cell phone or a landline, is about 800 pounds. So once we pick it up, if we don't get quick response and service, you might as well forget ever calling us back. I'm a big advocate of motivational interviewing, and I believe that all the first responders that I deal with are educated, are capable, are great problem solvers. They just have too much going on in their head, and we have to kind of delineate through that and work at steps. We're not digging for that giant egg basket. We're just trying to talk about the services, and this goes back to the trauma-informed care. At our program, we don't do trauma therapy. We do trauma-informed to talk about the surface, and we don't get into EMDR because that could be a 2 or 4 month process. We only have 30-something days with people, so we don't want to start something we can't finish. But I'm a big fan of MI, motivational interviewing. I don't want, as a first responder, I don't want somebody to tell me what to do. So I try not to tell them what to do. A lot of people will say, well, what do you tell them? I go, I listen probably 80% of the time. I ask very direct and open-ended questions to allow them a safe space to share what they're going with. If I don't know what is going on with them, how do you treat them?
That's a great point, Dan. And you're both speaking about trauma-informed care. Terry, you and I had talked about that. Let's kind of share that because that is one of the questions, trauma therapy versus trauma-informed care. I'd like to hear from both of you on describing what that means. Terry, you want to start that one?
Sure. So the trauma-informed care, like I briefly mentioned earlier, it's about safety. It's about focusing on the individual, not to re-traumatize them. It's recognizing that the trauma is affecting that individual emotionally, cognitively, physically, interpersonally. It's being aware of what may re-traumatize them. It's having transparency with that individual, helping them to build peer supports, helping them also recognize the impact it's had on their lives in a sense, like Dan said, kind of keeping it at the surface at this point in time. Also, it's about empowering that person. During the traumatic events, they didn't have a voice. They're in action mode, so now they do have a voice. They're able to put words to what happened, have a voice in their treatment plan. If that does mean then going into trauma therapy, which could be, like Dan said, EMDR, it could be CBT. There's a variety of different techniques and approaches to get more in depth into that, but it's allowing that safe space in order for that individual to be able to start opening up about their trauma. It's also recognizing their secondary trauma that could be going on, which is their fear of administration, their fear of talking about what's going on, perhaps even their fear of some moral dilemmas that they've been placed in on the job. Brotherhood versus, policy and procedure. That's a fine line that a lot of first responders in all arenas have to walk at times. So it's recognizing that that's also a part that's going on. So it's empowering and allowing them to recognize the resilience that they have within themselves.
Dan, do you want to add to that?
Yeah, I sure will. But the doc did a great job with that. I'll just add the basics of it. 2 things. One is I think of Bill Murray and baby steps. You have to treat are individuals, and there's a reason for that, is because, as the doc mentioned, trying to put our thoughts into words, then actually verbalizing those thoughts is a big step. I say that because the first time I had a critical event where we lost 2 kids, and I was actually at the firehouse the next morning. I was at the program that I worked at back in the 80s, and several workers noticed I was different. I didn't notice it, but they did. Some of the workers poked fun at me to get a response, and I did not respond to them, which was different. Usually I'll come back with a lighthearted response or a joke or giggle. The other person, who actually now is my wife, asked me a question: so, what's going on with you? And I gave the typical response: nothing. And because I couldn't verbalize it, at some point, she asked me again. She asked me again. She asked me again. And I didn't get mad, but it was about that safe space. And I'm like, maybe it is safe for me to offer that. But I wasn't worried about necessarily always the words. I was wondering about my response too, because I haven't had this critical response before. And I don't want to be in an open environment and start bawling my eyes out, go, the hell's wrong with Dan today? So there's 2 sides: how it's going to be received and how I'm going to receive it as I verbalize it. So at some point, I finally felt comfortable and safe enough where I shared about 10 words. And that was a breakthrough, I realized. To this day, I can think about it. And I mean, that's 30 years ago, and I can share it. I still get a response inside of me, which you wouldn't know, but I'm aware of it. Before, when that happened, I'd shut down. And so I've learned, dealing with people, we're not going to the heart of the matter, because they would be a ball of jelly here for the whole period of time. We just want to we use things like art therapy, equine therapy, and DBT to help them understand that it is a process getting from the trauma, first or secondary, the thought, put it in words, and actually saying them. Sometimes it's just putting them on paper in a journal or in art therapy, and then maybe at some point talking about it.
That's an interesting perspective, Dan, and I appreciate both of you sharing these different ways of thinking about it, because I think about, if there's an event and you know somebody who's a first responder, what are you going to do as a caring family member? You're going to call them and say, are you okay? Were you involved? How that could, the way you're describing this, Dan, is maybe we're not ready to talk about this yet. And the people that care about you most want to be supportive, family members, loved ones, but that may actually create more distance and compartmentalization, is what I'm hearing you say.
100%.
In that regard, thinking as from a clinician's perspective and also from a family's perspective, how do we provide that support?
The simple thing is, I already mentioned it, and I learned this word, not like I'm smart, but I learned it from somebody else taking a class, is the self-efficacy. Tell me how you've gotten through something similar before. And then what they do is they go from the event that they're struggling with to an event that they've been successful with. And that builds the ability to say, so once they talk about the successful thing, then we try to pair those 2 events and say, hey, you've been through this before. How can we, or can we, do you think, can you get through it? And then secondly, how can I help you through that journey? If I come in telling you what to do, that's the same thing as me coming in and seeing you struggling with a door, trying to pry it and go, give me the axe, and I tell you, go fly a kite. So we're the same thing with our emotions and our feelings. Same thing with anybody in crisis management. I would imagine even clinicians, or a teacher trying to tell another teacher how to run their class. So I usually ask a lot of questions. How did you do it before?
And if I
Go
may,
ahead,
Dan, I think you brought up an excellent point too with, how can I help? I think that's so important, because we all have a different set of needs and a different way in which we cope, especially after a critical incident. Some of us may want our loved ones around us, and some of us may want to isolate. So it's having our family be able to say, how can I help? I appreciate you saying that.
Well, our body responds. Everybody will, I mean, I've been in this field for 36 years and people will say, well, I got to do something for Dan. It's like, did Dan ask you? Or
Right.
do you feel that need that you got to do something for Dan? And many people these days know about CISM or peer support or interventions, and they'll be like, I got to go talk to him in 24 hours. Who says you got to talk to him in 24 hours? If somebody punched me in the stomach, it's going to take a while for my body to respond to that and be ready to be able to maybe have a conversation about that. So from a critical event, you said it. How can I help? What does the word help mean? And when would you be willing to have that conversation?
This really highlights, I think, the importance that you were both mentioning. Terry, you said letting that individual, the client, kind of guide some of this process and have some of that control as to where their readiness is. And I like, Dan, how you're saying focusing on the strengths and kind of pairing that journey really is kind of the process of healing. I think, could you both speak to, what can a first responder expect a little bit more in detail when entering into treatment across these different levels of care? Terry, you're working in the outpatient, private practice setting, and Dan, you're working more in an intensive treatment center where you said 30 days is kind of where we're kind of looking at, which is a more intensive and longer term. But then the discharge process is probably outpatient, private practice. Terry, given that you're the first line in terms of somebody coming in on their own to seek support, how would you speak to a first responder on what they might expect? Are there any more details you can provide on that?
Sure. Well, first, what I'd like to do is to normalize the therapeutic process, kind of take away the labels of that you're crazy, that this is even lifelong. Sometimes we just might have a bump in the road and a couple of sessions and you're on your way. Other times we might be having later down the road a more difficult conversation where things might lead to more intense treatment. However, I like to normalize it. I'd like to be able to kind of put down my pen and paper and just have a conversation with the first responder and let them know that I am fully present and that I understand the difficulties and the hardships of even coming in and making that phone call, and that I am there to support them in whatever needs that they have. And going back to, it's at their pace. Whenever they're ready to start opening up about what they've experienced, what their challenges are, what their goals are, it's completely at their pace. I've had some individuals where it might not be until session number 10 where, okay, I know I have to deal with this and let's start talking about it. But it's building that trust. And I do understand that lack of trust coming in. I also like to explain what usually happens to the brain in a sense. When you have a traumatic event and the brain is trying to find, okay, where do I put this? What is the person gonna experience? And kind of normalize that process. Not that they're, going crazy, so to say, so to speak. That's one of their fears, saying that, no, you are gonna most likely experience some flashbacks, some disturbing recalls. A lot of individuals will even say that they have, olfactory hallucinations. They'll smell the blood and be triggered by that. So we'll go through that this is normal. It's uncomfortable, it's normal. And through the healing process, the hope is that it will dissipate. And like Dan said, even going 30 years later and have worked through trauma, most people wouldn't recognize, but there might still be those little triggers that come up. You might feel it within yourself, but then you're able to recognize, okay, this is what it is. I'm okay. And then you're able to then work with that without it impacting you day to day anymore. So providing psychoeducation.
Dan, how about your perspective on that?
Yeah, so it's good It's good to hear Terry speak, because I could tell you when I first had the idea of Florian, there was only 3 programs in the country that focused on first responders. I don't even know how many outpatient programs, if any, did. There's probably first responders that provided that care, but she mentioned about smell. I wonder how many clinicians are aware that, our greatest sense is smell. And when we come into a room, we see, but we smell first. And if it has a comparison to pairing to events that we've experienced in a job, we go right back there. So one of the key things about choosing to work at Rosecrance was that it didn't have a hospital feel. It's not a locked facility. It doesn't have white walls. It's very beige and calming. There's no bleach smell. It doesn't feel like a hospital, because many people that have programs that are hospital based, I'm not going there. That's where we bring people to that are sick and die. And that comparison is not good. So every clinician should be aware of the odor and the milieu as we walk in a room, because I guarantee you, every time we walk into a space, we're eyeballing everything, because we have always been taught situational awareness. First impressions are key. If we don't have a good first impression, they're not staying or not coming back. So one of the key things that we do and about normalization and information is that when somebody comes into our facility, the first thing happens is I get alerted, or one of my team members get alerted, and I try to meet with them and have a conversation, just a conversation, not like, what are you doing? Why are you here? Doing that 32 question and tell me about your history. What brought you here and how can I help you? Basic common questions. So we meet them in the health center, answer as many questions as possible that they're willing to ask, and try to fully inform them, because I think we know from a success standpoint, the more we know about an incident or about a situation, the more effective we'll be. So that's the same thing here with treatment. They need to be well informed to know the expectation. Otherwise, what we don't know, we make up. And we're like, oh, we're thinking one flew over the cuckoo's nest. We're thinking of lobotomies. We're thinking of medication. We're thinking about our last experience as opposed to the current one. And that's what we do. We base it on our experience, as opposed to one of the teachings that we try to do, and I think you all do as well, is what does mindfulness and being present mean? Because we're always judging and assessing. You go into any class, and I just say this because having done classes with the Illinois State Police and other officers and fire and EMS and nursing, you want to find out where the police officers are? Go to the back of the room. Because they're back there and watching everybody. And they probably know more about you than anything you put, because anytime I've ever met somebody, they know more about me than I do.
That goes to, you mentioned EMDR somewhere along this line, and back to the question of transitioning from trauma informed to trauma expert. How does EMDR fit into this? Terry, you want to hit that one?
I've had to make a couple of referrals. I do my trauma work, trauma-informed care, and then I also use the cognitive behavioral, and then mindfulness. I have made referrals to other clinicians when my first responder is needing a little bit more. We'll just say a little bit more. So I've made referrals for EMDR because I am not trained in that. That is on my list. And I've had positive feedback from the officers that have returned after having, approximately 12 to 16 sessions of EMDR, where they have been able to have symptom management, stabilization.
But it's not necessarily a first kind of go-to then. It's something that I think maybe you could be referred to as in the process of your treatment if it's needed, is what I'm kind of suspecting you're saying here, Terry.
That's what I have done on the few occasions where it's been needed. I've made the referrals out. Oftentimes providing the psychoeducation, providing the narrative therapy, helping them understand what's going on and challenging the thoughts and identifying some of the irrational thoughts that are going on has been able to assist them, but then also knowing when to refer out.
Great. We have a couple of questions here I want to read to you both, and being mindful of time here so we can get to them. One is, do you think clinicians are a bit overly confident going into work with emergency responders because of previous work with civilians and trauma? And kind of going along with that, is there a difference working with people experiencing repetitive exposure to trauma versus someone that has had a single experience?
So those are good questions. What we try to do, and what I did as the EAP for the Chicago Firefighters Union, is go into facilities and educate people on how to deal with us. We're great people, but we get overexposed, a cumulative effect, and it kind of goes hand in hand. I learned early on in my career as a clinician back in the 80s and 90s that after a few years, I realized I didn't know a whole lot. And there were a lot of different demographics. And as I went on, I'm like, boy, I got a lot to learn. And I went through college. I grew up in, a first responder world. My father was a recovering alcoholic and had mental health issues. I've done a lot of, anyhow. So I'm like, after about 6 years, I'm like, I gotta learn a lot more. Nobody really teaches. So this is why it's great to have this forum. 8 years ago, there was nobody talking about first responders. There's not a class across the country, I think, you could take on first responders. So if a clinician goes in thinking, oh, I had a couple of experiences, and somebody, I watched the stuff on TV, not that everybody does, but like Chicago Fire, it's based on real stuff, but it's dramatized. So I've been doing this for 36 years, 22 years with first responders, and I'm still learning. So I am no expert. I don't know who is an expert, but I certainly have a specific focus on that. And if you don't put a greater majority of your time on the first responders, you're not going to connect with them. So if you have, just like the individual has to be intentional to put their recovery and their mental health first. If they don't, they're not going to be very successful. And if the clinician doesn't realize that, and most military people know this that do 4 or 6 years, they look at us that do a 15 to 30 to 35 year career like, oh my gosh. I mean, I had to deal, they'll say, hey, I had to deal with the military and certain things, condensed process. But for many of us, we have a lot of sleep disorders because we just don't sleep right. The average clinician probably doesn't understand that. It took me 2 years after retirement to sleep through the night for a variety of different reasons. So there's a lot of different things that I've learned that about myself and about people in our careers. If you don't have an outlet, you'll create one, good or bad. And that's where, like Terry talks about, in a sense of, coping and grounding and kind of basic stuff. You want us to fix your house, put a roof on, do your plumbing, put out a fire, catch a bad guy. That's second nature for us. You want us to sit still and focus on our thoughts, forget about it.
We have another question here. You have experiences as a first responder, as a non-critical first responder. So they have police, fire, EMS in parentheses. Any thoughts of how to best relate? I try to be transparent and say what I am not, that I have not experienced what they have. However, I try to emphasize what I can bring to the table. Is this a good approach?
I'm a firm believer if you give a disclaimer. Anytime I have people, and I've done a few symposiums for first responders, I tell the clinician, if you are not, go up there and please be vulnerable and offer that. But say what you know, stay in your lane. So I think that's a great approach if they're upfront about that.
And I would just I would agree with Dan, and just like to also add, I think the most important part is just to be able, first off, to be upfront, and then the second is just to be present, just to be fully present with the first responder. I think that is so important.
So one of the questions that has come to mind, this come up about confidentiality and privacy, and you did speak a bit about that. And I'm wondering, the elephant in the room, why would a first responder not want to be entering into treatment? Well, there's some risk, in a sense, to, their employer having access to records, the impact on their FOID card, fitness for duty, et cetera. Can you speak to these concerns in the context of both programs in your side, Dan, and also Terry from an outpatient perspective?
Oh yeah, I could tell you that, well, let's just go back to when I was the EAP. I was actually a fireman all the way up to battalion chief and still in the position of a union representative from an EAP. And every single time somebody would say, hey, is this between me and you? So we would have to discuss, and my full intent is to discuss the confidentiality aspect. Throughout my career here at Rosecrance, we have fluctuated with the people that come in here from a first responder kind of concept. In the beginning, it was very heavily fire and paramedics. Then it leaned towards correction workers, and now it's a lot of nursing and military personnel. We get very few police. And I can tell you this from my own understanding from my own father and many of the people that I worked with. Number one is we don't want it to affect their job, and who are you going to tell? So that release of information is a critical thing in an explanation when they come in here. Not only do we have to ask, who do you want us to communicate with? Who don't you want us to communicate with? And there's not a piece of paper for that, but we just want to let them know, hey, we're going to maintain your confidentiality unless those four things that, we are mandated reporters. But with police specifically, and I know this from my own father, most police officers that I know will go out of state because they don't want any connection between their substance use treatment or their mental health treatment coming back to their job and affecting their FOID card or FOID card. And what I can offer you that's one of the reasons why I'm here at Rosecrance. We're not a locked facility. We are not a mandated reporter for the FOID card. And then you get into the concealed carry license where, again, we are not a mandated reporter here. And we try to let those people know, hey, if you have a FOID or if you have a concealed carry, these are your requirements in a sense by state law. But for us, unless you fit one of these four things, and obviously the big one is a danger to self or others, or you're in a locked facility, that precludes you from having that FOID card. And then the next time you go to renew your CCL, your concealed carry license, you have to self-report. We don't have a requirement by law to do that. So it's left up to them.
Thanks, Dan. Terry, do you have anything to add to that?
Similar to what Dan was saying. So at the initial onset, when I meet with the first responder, I do go over limits and rights to confidentiality and what being a mandated reporter is and my duty to warn. I do also, though, let them know that sometimes we do have these thoughts, and just because there's an expression of thoughts of harm to self or somebody else doesn't necessarily mean that I'm breaking confidentiality right then and there. We're going to further assess, we're going to have conversations about it, because I think it's good to talk about it and have it out in the open versus more concerning if they're keeping those thoughts to themselves. And in that regard, it is a major concern. I also let them know that they are my client. The department's not my client. unless it's a fitness for duty evaluation where they're coming to me as a referral based on requirements for a fitness for duty evaluation. And like Dan said, they're signing a release form saying that I can talk to the department and disclose, but that's very specific in those situations. I have also had, Dan had mentioned, officers going out of state for some of these concerns. I have had first responders who have not wanted to go through their insurance or through their EAP, who have paid out-of-pocket expense so that there is no record, that nobody ever knows that they were even in treatment. So very, they're getting the help, and that's what's important.
There's a lot of barriers in regards to confidentiality, and there's guidelines that we have to follow. You all know as clinicians, so we can't skirt around that. But what we need to do is, if that person doesn't bring up that concern, as a clinician and a responsible party, you got to talk about that 800-pound gorilla in the room, so we can alleviate that concern.
Thanks, both of you, for that. I think it is an important, definitely an important thing to consider. And we want to, the goal is to reduce all the barriers so that people that are in need of support can obtain those. And as we're kind of closing down on the timing of this, let's talk about some additional resources. So, how can clinicians who are interested in more information and or first responders or family members who are interested in more information get in touch with both of you? Dan, can you give us, your contact? And we can certainly, this video is going to be available for recording. We'll put the resources on our website, as well as on the YouTube channel where this will be available. But Dan, how can they connect with the Florian Program or Rosecrance for more information?
Yeah, I think you could go on the website, rosecrance.org, and find the Florian Program under treatment. And if not, you can also call the 815-391-1000, and hopefully somebody knows who I am here. they'll get me here, and I have an office number, but yeah, it's 815-391-1000. I'm happy to answer any question of anybody. Not that I have all the answers, but that's how to get hold of me.
And I know there's wonderful informational pamphlets on your website about Florian as well. They're very informative, and I'm sure that they all know you, Dan.
What I found out from my son is I think you could Google me too, and you could find me. So.
Yep. And Terry can be reached at the Konick and Associates website at www.konickandassociates.com. And, her bio's there. You can read a little bit more about her. We will also attach a recording of this link to the site. Terry, you had some other resources too for first responders and or clinicians that are interested in learning more. What are some of those other resources?
So Bank the Blue is a non-for-profit organization who helps first responders with destigmatizing mental health and linking up for services. Also, there's 911 at ease and Copline. And Copline is a hotline. It's for resources for first responders, and it's trained retired law enforcement officers that assist with that.
Yeah, Copline is copline.org, and their number is 1-800-267-5463. And 911 at ease is a confidential counseling center, like you said, Terry, for first responders. That can be 911aei.org for those who are interested in more information about that. And they have a wonderful website as well. I appreciate everyone who has tuned in today. And thank you very much to our expert speakers today for sharing all of their wisdom and information to us about this much needed topic. And thank you again, everyone, for tuning in. And again, please feel free to reach out with any additional questions.
I would say, Lisa, thanks for creating this platform. Terry, great to have a conversation with you over Zoom. I guess what I would say to anybody out there is if they want something else, right? we're happy to talk about that specific thing, and doesn't have to be next week, but got to provide the knowledge.
That's what we're hoping to do.
Yes, thank you. And nice talking with you too, Dan and Lisa.
I hope everyone found this informative, and please do reach out if you have any additional questions to any of us.
Will this be, somebody asked how, if somebody couldn't make it, I had somebody reach out saying that, can they access this somehow, the video?
Absolutely. We are going to put the video on YouTube, and we will have it on our website, and we'll also send that to you, Dan, too. You can disseminate it.
Perfect.
Wonderful. Thanks again for tuning in.
Thank you.